My name is Derek Fales. I'm the Associate Director with Developmental Disabilities and Brain Injury Services with the Office of Aging and Disability Services. I want to welcome you all to day 5 of our statewide tour on the lifespan waiver. Like I said earlier, for those who are in the room, Dr. Lisa Mills, my colleague, she is a consultant with the state of Maine helping with the design of the lifespan waiver. Is delayed, so she should be with us shortly. So I will get started to keep us on time. What we wanted to do with this statewide tour, talking about the lifespan waiver, is to talk about how do we get to where we are today? What are the things that we've changed as a result of public comment? What are the things that stayed the same as a result of public comment? To talk about key design areas of the lifespan waiver, to talk about what they mean as a result of public comment. There was some clarification that we're provided as a response to public comment that we'll share today, and then talk about next steps. Also provide an opportunity for questions and answers. For those who are in the room, the bathrooms are outside of this room and down to the middle and to the left. And there's also a water bubbler there as well. For those who are joining us via Zoom, welcome. And we also invite individuals who are on Zoom to email us or contact us with any additional questions or comments, knowing that you're not here in the room, and sometimes there's just some organic conversations that happen when people are face to face. So I just recognize that, and we'll provide at the end of the presentation links for individuals to provide further feedback. So first, I wanted to give some quick updates. So first, for the lifespan waiver, that is when we talk about what that is or what you have all been able to react to, that's 2 waiver applications. So those 2 waiver applications are a 1915C waiver. That application, I brought it with me. It's 300 pages that talks about how individuals enroll on the waiver. It talks about medical and financial eligibility. It talks about services, what the services are, how they can be delivered. It talks about who are the providers that can deliver those services, the qualifications, the quality standards, the safeguards, so appeals, how individuals can grieve concerns, make complaints. And also it talks about sort of the financial, how does the state intend to cover individuals who have needs, and how do we budget and pay for that? So if we remember, our partner is the federal CMS, the Centers for Medicaid and Medicaid Services. And so these 2 waiver applications, they review. The second waiver application is the 1915B4 waiver. What that waiver is, an application from the state to CMS to waive participants' right to choose their community case manager. What that means is we have a selection process through a request for proposal where we invite community case management agencies, children's side and adult side, to submit a proposal of how they would deliver community resource coordination to the state. Our goal is to pick a minimum of 2 providers per region to ensure that there's more than just one provider for individuals to choose for case management. There's also options within this request for proposal process for there to be multiple statewide case management agencies, as well as case management agencies that can choose to cover multiple regions across the state. So there will be more than 2 per region, and there may be up to 30 agencies statewide, which is much different than when we are looking at both children's and adults. That is over 100 agencies that provide case management. So that brings it down to a more manageable group for the department to provide better technical assistance and support. So just again on this slide, again, the purpose of this statewide tour, and this tour is just one of many that we're planning in the future to continue the dialogue and communication as we learn about the experience from people and providers who are living the services once the lifespan goes live. We also wanted to address other public comments as a result of these, to share next steps, and then to answer your questions and hear your comments. When we talk about the lifespan waiver, early on in the discussions with providers, with participants, with people, with families that are seeking services, advocacy groups, we wanted to make sure that this waiver was coming on with the least negative impact to current services for people who are in sections 21 and 29. So what that looks like is some states, when they do a new comprehensive waiver, they tend to close out existing waivers. So they may bring in a new waiver with the goal of reducing the amount of waivers that they need to operate. In Maine, to ensure that we still have 21 and 29 available as options, so individuals who are enrolled and satisfied with their services on 21 and 29 can continue to receive those services, and we would not make any changes. What we are making for changes for 21 and 29 is that new enrollees, so people who are not in 21 and 29, once the lifespan is operational, they would not be able to go onto 21 or 29. They would choose services under the lifespan waiver. Another area that we wanted to ensure that we were doing within the state is to ensure that there was no waiting list for Section 29. So we wanted to ensure that by the time lifespan opens, that there wouldn't be nobody who is waiting for Section 29. So where we are today is we have individuals who have applied for Section 29. They're going through that process to determine medical eligibility. Once we establish medical and financial eligibility, then we're giving what we call a funded offer letter, and they can select services and begin lifespan services. We also wanted to make sure that we were starting small. So with our consultants, hearing from families and providers, we wanted to make sure the lifespan waiver starts small and is a phased-in approach. We believe that that's a responsible way to understand what the experience is. And so there's a phased-in approach. So there are around 50 individuals that would come on to the waiver each month. We would be able to understand what's happening, review documentation, progress, understand what people's experience are, and be able to look at what adjustments we needed to make to operational guidance and to any procedures to help smooth things along the way. The other a change that we made with the lifespan waiver, the last item on this slide, is regarding Section 20. For anybody who does not know Section 20, that's Section 20 of the Maine Care Benefits Manual. That is a waiver for individuals with other related conditions, so cerebral palsy, a seizure disorder, or other related conditions. So that waiver is a relatively small waiver, and we were planning to end that waiver, end Section 20, and incorporate that into the lifespan waiver in year 3. For anyone who knows around the budgeting process in Maine, it is just a 2-year budget. So we don't actually have a budget to include individuals with other related conditions. Right now, as the legislature approved a law, the legislature asked the department to create a waiver application, to submit that to CMS and create a rule and bring that rule again before them. And the legislature appropriated funds for us to start this lifespan waiver. They did not appropriate funds for 3, 4, or 5. And so that means we'll have to continue to work within the department and the next administration on creating a budget and discussions on whether or not we bring in Section 20 into lifespan in future years. Next, I'll just talk about where we are. How did we get to where we are today? So the lifespan waiver is a result of 5 years of planning and partner engagement. So when we first started to think about Section 21 and 29, what was happening, what was the experience of individuals, and what we were hearing from families and participants. So we knew we needed to have new services, new opportunities, especially to support what we were hearing from families who were saying that there's a cliff from children's services to adult services, that there's a cliff, and many years asking the state to address that cliff. And so this is one of those designs where we talked about how can we ensure that a youth can transition into adulthood and not have to change between many services. So when you think about youth, what happens now is a youth will have a children's case manager, they'll have children's services, they'll reach an age where they can no longer continue with those children's services. So they have to end their case management and they have to end their children's services. And at times, families don't know about what's the next step. Sometimes families said, we didn't know that there are adult services. And so the lifespan waiver ensures that youth starting at 14 can come onto the lifespan waiver and they never have to leave that waiver as long as, of course, they maintain medical and financial eligibility, which are things that currently we still have to ensure that those pieces happen on a yearly basis. When we were talking about designing new services and supports, there were multiple statewide tours. Again, this is the third statewide tour for us. The director, Betsy Hopkins, first started those tours with Dr. Lisa Mills, and now I'm here today with all of you. Also, we started off with a concept paper. So as we were talking with families and individuals and talking about what services and supports could be helpful, there was a concept paper that we created. We sent that out to public comment. We received comments on those services and supports in the concept paper. We've made changes as a result of those comments as we were writing the waiver application. We also had multiple advisory committees to really talk about various aspects of our system, about the lifespan waiver or new services and supports to help us with the design of the waiver. We also knew that providers and all of you would need support around readiness. So during the American Rescue Plan Act, there were funds that the state set aside in a grant process for providers to apply for those federal funds to help with readiness, to talk about what it would look like within their agencies to think about delivering services under the lifespan, especially to think about targeting youth. So this lifespan waiver really is designed to target and be a waiver for the next generation. So we've heard oftentimes of what people who are coming into our system want from services, what they don't want, and we hope that the lifespan waiver offers opportunities to meet people where they are and to provide those stepping stones throughout their life. One major change that we made to the lifespan waiver as a result of public comment is we pushed out the start date by 7 months. So there were comments talking about we can't open this waiver, we can't deliver services, hire staff by October of 2026. So if you looked at the waiver application that went out to public comment, it does have an effective date of October of 2026. We've pushed that effective date out to May of 2027. This slide talks about changes, this slide talks about the things about the lifespan waiver that we did not change. And we didn't change them because we didn't have any public comments that said we should do things differently for these design elements. And when you're bringing out a waiver application, once you go to public comment, once you submit it to public comment, so it's a published document, the state's can't make changes unless we have public comment to that without, sorry. Um, so I'll step back again. So this slide does talk about things that are stayed the same as a result of public comment. So in order for the state to make changes, oftentimes we have to have a public comment that says, please make this change, and here's why. And that's part of that process to ensure that the public always has the most recent application and that they can react to that application. So we didn't have any public comments to say that we shouldn't start serving youth in transition. So youth will begin to access the waiver at age 14. And there are 500 funded offers for youth. So the majority, over 75% of lifespan waiver is serving youth. It's serving that next generation and service and supports to meet what we've heard from people and families of what they want their life to look like. We also made no changes to section 21 and 29 to continue to be available for people who are currently enrolled for services and people who are seeking to continue or to apply for section 21 will continue to enroll those individuals up until the lifespan waiver goes live. We also continued to talk about how to address any waiting lists more quickly. So we're putting things into place to ensure that people are not waiting for those essential services, that they have access to services. So when we're moving into the lifespan waiver, people can still access section 29, still access section 21 if they meet that criteria and we have those slots available. We also didn't make any changes with the design for accounting for individuals who have exceptional or extraordinary medical or behavioral needs. Again, the rate methodology and the rate study that we have is to support providers on having the resources to help individuals and support individuals' goals and outcomes who have exceptional behavioral or medical needs. And we'll talk a little bit about that in later slides. We also have heard this for well over a decade, I would dare say 2 decades, of bringing section 21 to a true per diem. And within the lifespan, we continue to encourage and support the system designed to have a true per diem. And again, the state did not receive any public comments that we should change any of those design elements. Next, I'm going to turn it over to Dr. Lisa Mills.
Apologies for being late. This is the first day this week I got lost. So we want to talk a little bit, to give you a little insight into what we think youth will do when they become part of lifespan. So since so many slots are for youth, we thought we'd give you kind of a sense of how we think 14 to 17-year-olds would engage with lifespan and why it would be beneficial. So we had an example. He's not here now. He's right here with me. 16-year-old. Imagine a 16-year-old living with parents who qualifies for the lifespan waiver, is still in school, receiving special education services, has some main care services like occupational therapy, speech language therapy, maybe has some Section 28 services for behavioral supports, and then also is engaged with vocational rehabilitation because we know voc rehab is getting into schools, working with youth much earlier than they had in the past. So imagine he's got his first job at a recycling center in town. So what would happen when he enters lifespan? He would get a community resource coordinator, which I will talk more about as we go through the presentation. The case management role is called community resource coordination. And that individual would get to know him and work with him and people who know him well and are involved in his life to start planning for that transition to adulthood as soon as he enrolls. So as early as 14, but it could be 15, 16, 17. Start with what do you want life to look like? What kind of supports and services do you need as you transition into adulthood? Rather than that planning only starting when he's actually becoming an adult. So a lot more opportunity to plan ahead and for Joe and his family to feel like they know what's going to happen when school ends. That's part of what we want Lifespan to do. So imagine Joe and his family decide, Joe really wants to move out of his parents' home. He's got an older cousin that lives nearby. He'd like to move in with that older cousin, and he'd like to hire that older cousin to provide some of the supports he needs at home. So what the community resource coordinator would do is work with Joe and his family on figuring out how that plan would look in Lifespan. So what services are available, how does self-direction work, and including making sure that Joe's cousin understands what's all involved in being a paid self-direction worker. So a lot of things worked out in advance. So when he gets to the point of needing that and moving out, that the plan is already there. And it's just simply a question of moving forward with the authorizations. The other main thing that we want the CRC to do with Joe is to say, what can we do for you now before you transition to adulthood? So we got this plan for what's going to happen in adulthood, but how can Lifespan fill any gaps in supports you might need now while you're still in school? And there's a couple of things we think will be quite probably used a lot in Lifespan. First, youth typically need supports and are not getting them during the summer when school is out, or school holidays, or after school, depending on their needs. And so that is one thing that Lifespan will be able to address. And for example, if during school holidays, he wants to be able to get around the community, he wants to be able to figure out, how am I going to be involved in my community when I graduate, when I no longer go to school every day, that we can start those services while he's still in school to help him with that. As long as we're not authorizing them at the same time he's supposed to be in school, that Lifespan can do that. The other thing is vocational rehabilitation. If Joe's got a job and he's being supported by vocational rehabilitation, there comes a point at which vocational rehabilitation says we're done. It's a short-term program. But if he needs supports in employment to continue to maintain that job, Lifespan can pick up that whenever that happens. It does not have to be deferred until he's 18 years old or older. So if they stabilize him in his job when he's 17, Lifespan can authorize the ongoing employment supports. And then he has this goal of moving out of his parents' home and moving in with his cousin. So in all likelihood, he'll need some skills that he maybe hasn't learned yet. And so we have a service called Home-Based Independent Living Skills. You're probably familiar with it, that looks at targeted learning goals for learning skills to do things at home. And that could be authorized as well to help him with things like learning to do his wash or cooking simple meals. That skill plan, a learning plan could be developed for him through that service. The other thing the CRC will really focus on with youth is trying to bring together all these silos, trying to fit all these pieces of the puzzle together for the family. So school, VR, state plan services, the Lifespan services now, Lifespan services after he leaves school, and help that family feel like, okay, we know what's going to happen. This doesn't feel like a cliff anymore. We feel more comfortable with the plan. So the overall benefits for youth, based on what we heard about what would be the reasons to start providing services to youth at age 14, greater predictability for families and being able to do that, planning for adulthood sooner. Parents hopefully get to spend more time just being parents and not worrying about what's going to happen when this ends or that ends, and how do I get this other thing started? And then that really encouraging those partnerships and linking all these separate plans together so that there's one plan for Joe and he doesn't feel like he's being kind of fragmented. And then we think it'll reduce stress by allowing youth to and their families to make that transition to adult case management earlier. So once they get a CRC in lifespan, that CRC follows them through adulthood. So they keep the CRC roll in all through their adulthood. So some comments were about what is the future of residential supports if we start serving youth much earlier, if we're focused on what we hear youth and their families saying they want more independence, they want more involvement in their community, they want to have, maybe I hear people talk about, a couple of good friends, share an apartment together and get supports. How do we do that? What's the future of residential supports? Well, in Lifespan, we still have residential supports. We still have agency group home for those who need it. We still have shared living. And we are adding community supported living. And that's really in response to youth and folks who want to kind of, I don't know, the phrase is control your front door, own your front door, to just be able to have your own housing so that if you want to change providers, you don't, or you need to change providers, you don't have to move to do that. It's your home. And so we're looking at how to make sure we have all three options in Lifespan, and want to work with providers who may be already providing shared living or agency group home to develop their capacity to provide supported living as well. And we have some services specifically to help people find housing because we know that's a critical need. So we expect there'll be a transition and a change over time in the balance of residential services that are used by people in waivers, but we don't expect that to happen really rapidly in a way that we can't manage with providers. Again, if you diversify what you offer, of course, you're likely to always have what people are looking for. And we want to make sure that incremental change over time is done well, doesn't jeopardize any provider's ability to continue in the network. But we also recognize, we heard this week, there are a lot of aging parents doing shared living right now. So think about that group as well as coming up and needing a different type of support. So we don't think anything is going to change quickly, but we hope that everybody, understands and supports the idea that we need the broader range of options and to be really planning for future waiver participants. I'm going to let Derek handle this one. I'm not going to take that.
So this slide really talks about opportunities when the state is moving to a true per diem. And what does that mean? So currently, in Section 18, which is our brain injury waiver, and Section 20, which is the other related conditions waiver, there already is a true per diem. So we know that there's experience across the network of providers for over a decade of how to manage the staffing in their homes to meet the participants' needs, that they're able to upstaff, they're able to lower staff, and they're able to manage that on a day-to-day basis because there's predictability in what the daily rate is for each person, and that is in our rate methodology, it's changes based upon bed size. So recognizing that a smaller home has different costs from a home that has larger homes. So like a 6-bed is going to, for a provider, there are different costs than for a 2 or 3 bedroom. And so the rates are different across those bed sizes as well. So we also know that we do are intending to and are planning for rule changes within Section 21 and to ensure that lifespan and Section 21 can benefit from the same changes that we've made for lifespan. For instance, removing the requirement that there be a staff person inside that home, so a human being inside that home whenever there are participants in that home. So we largely we've heard this from members who are living in these agency homes who if they have a plan and they have don't have needs and they want to be alone, then that person and their planning team can put that into their plan. They can have the discussion with their provider and they can plan what that looks like for them. So they don't have to necessarily have a human being in that home when somebody who's living in their home is there and they don't have that need. We also have and will be including the use of remote monitoring technology within agency home supports. What that means is so individuals who, again, don't necessarily need a human body in their home, but they need support. They need a way for somebody to know when they need support, and somebody can know what's happening in the home. So there is the use of technology inside of agency home supports to continue to ensure that people are safe and supported even when they're alone in the home or if they're sleeping and they don't need staff in the overnight to be with them either. So we know this from Section 18 and 20 that when there's true per diems and the ability for staffing the home rests with the person and what they need and the providers to support what that need, that means that there's changes in staffing that can happen and to also ensure that there's staff available to deliver other services and supports. So when we think about the concern we've heard, if we're changing how we're staffing homes, that might mean that there's what's going to happen with those staff. And so if there comes a time when there's a home where the staff have more time, then there's other services and supports that we think would help those staff to continue their services and supports across the continuum of the person's life. And hopefully they can sometimes go with the person from whatever stage at life that they're at. We also know that individuals and families have talked about staffing. There's been a lot of discussion around the staff that are coming into people's homes now, staff that are in those agency homes, and what's that experience look like? And what we've heard is sometimes those staff who are well seasoned, well trained, can often have better insights into what's happening for the individual than newer staff and if there's a lot of staff. So sometimes we know that better trained staff and less staff can often be better than just a lot of staff in the home. That can sometimes be overwhelming and it can cause greater issues and concerns for the people in that home, especially when somebody has those higher behavioral needs. We see that often with our crisis services going into the home and trying to understand what 3 or 4 staff are doing when there's 1 or 2 people in that home, and it seems to be an escalation of behaviors. So we know that we wanted to make sure that there's enough resources so that those staff can be trained, well trained. We're doing that with our own staff as well. We have 2 staff members who are START coordinators. The START is a program through um, the from New Hampshire, and it's really specific to supporting individuals with behavioral and medical needs who have intellectual disabilities and autism. So we're looking forward to continuing to build our crisis system and training in that system, and then going out to agency homes to also support those staff and how they could do things differently and make sure that people's needs are being met. Next, I'm going to talk about annual funding range. So when we think about the lifespan waiver and we think about all of our waivers, every lifespan participant for the lifespan will have a specific participant group. So that means, youth who are 14 to 17, the transition age youth, we we've built an annual funding range. So think about a person's life. Your services and supports can ebb and flow. And so this is our way to budget, for the state to budget what we need for funds from the legislature. And we have to have a design that ensures cost neutrality for the waiver. And how we do that is by designing annual funding range. And so youth and from 14 to 17, Dr. Mills had talked about that we believe that those youth will have less services in the lifespan waiver, primarily because you have to use state plan services first. So you're using Section 28 services, you're using other main care services first before the waiver, as well as EPTSD, early periodic screening diagnostic treatment. I think so. Anyone can correct me too. And so those are another funding way, another requirement that the state has to ensure that youth have what they need to be successful. And so when you think about youth using those state plan services, we know that they would be using less services. So we're able to then describe and talk about how we would support those 500 youth on the waiver and what those costs would look like. Also, we had some comments that the belief around how did we get to this annual funding range. So there were some comments that talked about we were using an instrument, the CISA assessments, and I'll talk about that in a little bit, that we were using that to base and create an individual budget. And that's not what we're doing. We're not creating individual budgets. We're recognizing that people have needs and they have services to meet those needs, and those can change throughout the person's life course. And so we've created these annual funding ranges to ensure that we can plan for and build a system that as people are aging throughout their life, that they have the services and supports available to them to meet them where they're at. So the annual funding range is based upon a person's age. So if you look at the first enrollment, which is the 14 to 17-year-olds, we have planned for 500 14 to 17-year-olds accessing the waiver. And then also when you're thinking about the age and then the type of living arrangement. So youth are primarily living with their families. And so, and then you go across to the next participant group, which is those 18-year-olds into 21 or 22, which is the next enrollment group. And there could be a mixture of where they're living. Are they living in shared living? Are they living in an apartment? And there's an annual funding range to capture that, as well as to understand what is typical support needs for individuals. And then we're moving up. And so each of those funding ranges, when you add those services and supports, predicting what services and supports are, that creates the budget for the whole lifespan waiver as a whole. Also, there was just some comments again. We changed the name. I should have said that. I apologize. From annual monetary limit to annual funding range to better reflect that people, again, have services that are within a range. So some individuals will come onto the waiver and they'll only access community resource coordination or assistive technology because they're having other services and they don't need any other services at that time. That's not to mean that they won't need other services later on in their life, but those services will be available for them when they need them. So when we look at the waiver, so we have to make projections on the types and amounts of services the person will need in order for, so there were comments around our projections. So some of the services you'll see that we're projecting that in the first year, only a few people would be accessing the services. That's because the lifespan's not live, so we have no experience to base upon. And we are required to have a way that we're saying we believe X amount of people use this service, and here's how we are determining that. So right now we have to use historical data, so utilization data, and that's where our basis of here's how many people use similar services across other services now. And we do hope in the future, and we'll make changes in those projections in the future as we actually have the experience of what people are seeking for service and supports, and we'll be able to make corrections at that time. And also when you think about the cost of the services that are within those annual funding range, also think about the annual funding range as your core services. So these are the services that a person would likely need throughout their whole service plan year. And we don't anticipate that those core services would change very much. You would still need support in your home, skills training. You would still need access to that support. But, and we also base that core services range based upon the rate study from accessing data from 2023, reviewing that in 2024, and finalizing those rates and that rate methodology for 2025. So that then there was a public comment process where we took public comments around that rate methodology. And the rate methodology is a requirement that CMS has in order for the state to increase what we are paying for provider payments. It has to be based upon an approved rate methodology that CMS reviews and approve. States do not have the authority to just increase or decrease provider payment rates without having CMS approve that rate methodology. And lastly, an important note that there are services that are outside of the annual funding range. And if a person has an assessed need, the cost of those services are not counted against the annual funding range. And that ensures that people who have services around community integration and employment, especially services that are intermittent in nature, that there's no reducing the worry that that they would have any budgetary issues. And we'll talk about how we look at those exceptions process. We've designed 3 new exceptions process, 2 of which are not new, and a couple are brand new, and I'm very excited about that. And we'll talk about that in the later slides. So services that are included in the annual funding range, I'm not going to go through all of those services, but you will see that there are services that are grouped together. So personal and home assistance, home-based independent living skills training, respite breaks and opportunities, remote monitoring and on-call. Those services are residential nature, and so we've grouped those together. And if you look at all of those services, a person wouldn't have all those services at the same time. It's not actually possible that you could have all those services at the same time, or even half of those services at the same time. But it is a recognition that a person is selecting the service and supports, the type of service, the amount, and the frequency based upon what they need and to help them achieve their goals to live the life that they want to. This slide really talks about services that are outside of that annual funding range. So that's the behavioral support consultation. So having a clinician to support that person-centered planning team and that provider on the development of a positive behavioral health support plan or a modifying behavioral health support plan. hopefully those two terms are not new to anybody, as the state has moved away from allowing and authorize the use of plan restraints for adults with intellectual disability and autism. There are other services that are community integration and employment based. So benefits and works incentives counseling, career planning that are intermittent in basis. And so you have these services when you need them to better prepare a person for the next step. If you're thinking about employment and what does employment look like for you, um, what are your options available? And so we want to make sure that there's no worry that I need to think about I can't have this service because that means I might have to reduce another service. And so these services are outside of that. So that's never part of that conversation. And we will talk about further around person-centered planning and supports in a little bit. Yes. So on the right bottom of the slide, support broker and financial management services. These are two services for individuals who are self-directing. Currently in the Section 29 waiver, there is the combined limit of services. So in order that is important because the combined limit also results in your individual directed goods and services. So the cost of support brokerage and financial management service is that has to come first in your self-direction budget. So when you think about your self-direction budget is, of course, the person decides how much I'm going to pay my staff. So it's typical to see people in the state of Maine paying their staff $30 an hour. And what that means is you then have your total budget and you have to make sure that you've accounted for the cost of those two services that are really pivotal to help people with self-direction. So financial management service is really, think about that as your payroll and your human resources combined in one. And the support broker should be the person to help you around planning for hiring, recruiting, and what does that look like for your staff. Next, I'll turn it over to Dr. Mills.
So as we build a waiver where we really want to encourage community integration and employment, we recognize that a number of the services that are in that annual funding range that support employment and community integration have higher reimbursement rates than the facility-based day program service. So we didn't want for people to think I can't choose those services because I won't be able to get as much because they cost more. So we created from the beginning, I think Director Hopkins had this vision. We created an add-on to the annual funding range, which if individuals have in their person-centered service plan integrated employment path or job coaching, coworker supports, community relationship connecting, community connections assistance. Those are all for employment and community integration. The difference in the cost between facility-based day and those services will be added on to their budget. So it will basically equalize the service. There will be no issue around cost being a factor in choosing those services. We wanted to, shift now. Of course, we just talked about the budget and we got lots of questions about the funding and people's annual funding ranges. But we really wanted to ground ourselves back to what good person-centered planning is. And really, for me, good person-centered planning doesn't start with a budget, it ends with a budget. So if we're really building good person-centered plans, we're not starting with, you have this much money, how do you want to use it? We are saying to people, what are your goals? What are your needs to reach those goals? What are your health and safety needs? What do you want your life to look like? How far along the road are you to getting that life? What's missing? And then when you know what people need for supports to reach goals, to take care of health and safety, what are all the sources of support that are available, and what does the waiver need to do? And so you build that person-centered plan based on those principles. And then at the end, when you figured out waiver services, how much, how often, what's the rate, you figure out what that plan costs. And as long as that plan is in the annual funding range, there's no issue. We don't need to worry about that. So that's how we want to build person-centered plans, not starting with a dollar figure, but starting with what does the person need for their life. If the cost of your plan exceeds the annual funding range, as Derek mentioned, there is exception processes that people can use. So, but we may not have to use those very much because the annual funding ranges are kind of built on if you're this age, if you're in this type of living situation, and if you have this level of support needs. Based on looking at history, we kind of have an idea of what your plan will cost. So we've given you the range that we think it'll fit. It's not a use it or lose it scenario. It's not, in some states, individual budgets where they say, you have this much, you have this much. If you don't use it, they reduce your budget. It is not use it or lose it. That annual funding range, as long as you're the same age, the same support needs level, and the same living arrangement, you keep that range. Some years you might use more, some years you might use less, but it's not a use it or lose it model. So when we were doing a lot of advisory committee work and early discussions with people about this waiver, we did hear it loud and clear. If you really want this to work, it's pretty different, and you're going to need you're really going to have that case management role look different. And so from the beginning, early on, we kind of knew we were looking at a different case management role, and people were pretty clear we would need them to spend more time with us. We would need more engagement. We would need them to know the children's system and all the children's services and all the state plan services in addition to adult. So we knew it was a different role, and we want to start small with testing out this approach to case management in lifespan. And so we decided that the way we could do that was not to try to change TCM. Targeted case management is the purview of main care. It covers far more than just the waivers for people with IDD and autism. And it's a big lift to change TCM. And right now, the appetite to do it isn't there. You probably know main care is really, really busy with a lot of other changes. And so we want to create the case for the possibility that TCM could be changed in the future. And we're going to try to demonstrate the case for that in lifespan. So we created the service as a waiver service. It's not state plan. When somebody enrolls in lifespan, they will get a community resource coordinator as a waiver service. And we want to limit the number of provider agencies that deliver community resource coordination so that the state can adequately support them. Right now, there's over 100 agencies that do either children's or adult or both TCM. First off, with 680 people coming into the program, that doesn't really make sense to have 100 providers of community resource coordination. So our goal is that people will have a choice. There will be at least 2, but we will look for agencies that feel like they want to go in this direction, they want to try this, and that are willing to work with us to create dedicated community resource coordinators. We don't think mixed caseloads will be easy because it's very different. We realize in the short term, we may have to have mixed caseloads or other ways that we allow for the ramp up so that agencies are not out of pocket in that startup. We made some changes to the waiver for that. But we really want ultimately for these community resource coordinators to just be doing lifespan. By making it a waiver service, we also can pay for it differently. And so we are experimenting with a monthly unit of service, which gets what we heard from people is and folks doing the work is there's just so much time spent on documentation, so much time spent in front of a computer inputting information, and not enough time spent with people to really do what we want them to do. So by going to the monthly unit, we think we can reduce the amount of documentation that's done just for the purposes of billing. We can really focus on what kind of documentation is valuable to that person and their process. And we'll be able to pay for it in that way. A lot of states use a monthly unit for case management. They don't use a 15-minute unit, they use monthly. So we think there's a good basis for believing that this is a good direction to go, and we're gonna implement it in lifespan. So think of lifespan community resource coordination as a test flight, for lack of a better term, for how we might do broader targeted case management change in the future. We heard you in public comment, people saying, why don't you just change targeted case management, make these changes? And it's just, we also heard, don't be careful you take on too much here. You don't have the bandwidth to do it. And frankly, this is something we think we need to pilot and demonstrate the value of, and then we'll be able to get buy-in for broader change. So some changes we made in response to public comment, and some things we kept the same, but these are the highlights. The caseload maximum of 20 will be 27 instead of 35. The rates were based on 27. But we have said it can be exceeded temporarily to preserve access. We don't want anybody waiting for this service, obviously, and to preserve continuity for people. We also added language that any supervisor of a lifespan CRC can carry a caseload temporarily as well to preserve access and continuity. So these are ways to ramp up without providers actually being out of pocket. And we will look in the process of selecting the agencies that will be part of doing this in lifespan. Their contracts, so we'll be able to negotiate if a provider says, in order to do this, I would need these things to be temporarily allowable, including the possibility of mixed caseloads, because we heard you on that. Some folks expressed concern that if we limit the number of agencies doing this service, that we are going to limit access and people are going to wait. When a state opts to limit a network, they are required to have mechanisms in place to track whether people are receiving the service timely, if anybody's waiting. And if they aren't, they have to immediately address that. So you'll see if you read the application that we detailed out how we will monitor access and address any access issues. I always think access is really about the people to do the work, not the number of agencies. So we want to focus on making sure we have enough people to do the work. State, as I said, required to address access. And then quality monitoring, you'll see in the application the kinds of things we'll be watching to ensure quality is caseload sizes being where we want them to be, or grievances. Are we able to timely create those person-centered service plans? And what is participant satisfaction? So we will be tracking that and addressing issues if they arise. I'm going to shift gears to housing counseling. I mentioned community-supported living as a new option, and I mentioned we added services to help people find housing. Housing counseling is the primary service that we added that can help people develop a person-centered housing plan to help research and look into housing options, look into private landlord options, look into public housing programs, accessibility things, whatever it is. So we did hear from you that we had set the maybe standard for relevant experience a little high. That might prevent somebody from filling this role. We have a specialized training developed for people who are going to do housing counseling, so we know we can train them well. And then, so we reduced the relevant experience to 1 year and really left it up to you as the providers to determine what relevant experience applies.
This slide really talks about, we received a fair number of comments around children's case management. So case management that youth have now, and how does that work with the lifespan waiver? So when we talk about the goal of lifespan waiver is to build a waiver that meets the needs of the next generation. And those youth, 14 to 17 years old, will have a children's case manager. We hope. There are, of course, sometimes families that do not have a children's case manager, and so the community resource coordinator will be their first case manager. But for those youth that do have a children's case manager, that case manager is often already connecting them to children's behavioral health services. So the services under children's behavioral health services, when you think about Section 28 as an example, those services will continue for those youth. So again, when I talked about youth would continue to have those services under the state plan, that's that children's behavioral health services. So children will continue to have and receive children's behavioral health services, and they'll access the lifespan, and they'll receive those services that are not a duplication or are not available in Section 28. One of the items that we did talk about too was around the behavioral health home model. So behavioral health home model includes a key requirement to have a case manager. That case manager under the behavioral health model is a comprehensive case manager. Because community resource coordination is a comprehensive case manager, similar to targeted case management for adults, that is a comprehensive case management model too. You can't have two comprehensive case managers at the same time. And so individuals would have to disenroll from their behavioral health homes with their case manager and enroll with the lifespan if they wish to receive services under the lifespan. We also had comments around Section 28. So if individuals are already aware of the relationship between Section 28 and Section 29, currently in Section 29 rules, youth who have Section 28 have to disenroll and from all of their services on Section 28 if they wish to enroll in Section 29. We've worked a lot with the Office of Main Care Services, the Office of Behavioral Health, and Office of Child and Family Services to map out those services in the lifespan, to look at those services in Section 28. And we were able to come to the agreement that a person could continue with lifespan services and also continue with their Section 28 services as long as there's not a duplication. So we believe that there are many new services in the lifespan, especially when you're thinking about family empowerment, housing counseling, housing support, and housing startup, and assisted technology that don't exist within Section 28. And so there will be no blanket prohibition against people on the lifespan being able to access Section 28, which is a change. And I just give an example here of what this could look like. So a youth who has a community resource coordinator under the lifespan, they're accessing assisted technology and community transportation services. community transportation is not non-emergency medical transportation or net transportation. Net transportation is when you're seeking transportation to access a main care service. Community transportation is simply, I need to go from A to B, and I don't need a main care service to meet me at my next location. I just need a ride. And you can do that, and you can self-direct that. So you can also ensure that that your financial management service will receive a, transportation log, or whoever they determine that they want to receive how many miles people have, and then there'll be that negotiation again. The employer is the member or the family, and then they can pay people to transport. So if I need a ride and I'm self-directing, then I could pay my coworker, and if I'm not self-directing, then I would have an agency that would enroll to deliver that service, and that they would pay my coworker to make sure I can get a ride. We also did receive a fair number of comments around high fidelity wraparound case management for youth. High fidelity wraparound is delivered through, again, that behavioral health model. Because high fidelity wraparound case management is considered and as a comprehensive case management, again, you can't have two comprehensive case managers at the same time. And so a person would have to disenroll from their high fidelity wraparound case manager in order to access services under the lifespan. I also just want to mention there was one comment outside of one of our presentations where somebody was talking about that they have a service coordinator. So, or we call them SCAs, service coordination agencies, and that's because they're accessing public health nursing or other services on the state plan. Excuse me. You would continue to have your service coordinator and continue on the lifespan with a community resource coordinator, because that service coordinator is not doing comprehensive case management. So they're just coordinating those services such as public health nursing. So they're really just helping on finding a nurse and making sure you have that nurse and that the nurse is getting paid. They're not doing anything with monitoring your other services, versus a comprehensive case manager is looking at all of the services and supports, natural supports, and what that person looks like, and monitoring for health and safety on an ongoing basis. There were also many comments around the wait list. So the wait list, in referring to section 21 and 29. So again, what I talked about earlier is for section 29, essentially, we have no waiting list, meaning that there are funded offers, and as people are becoming medically and financial eligible, we're doing that determination. We're sending out that funded letter so that they can then select their services and finalize a service plan. On section 21, that is a different matter. So there are individuals who have been waiting for a number of years for that service. Most of those individuals already receive services on section 29. And so the goal of the lifespan, again, is to serve youth. One way we want to make sure that people who need services and have access requirements for a service now is to create reserve capacity. So this is not new to the state of Maine. In section 21, we reserve capacity for those who need it most. So within the lifespan, we have additional reserve capacity. We have additional reserve capacity categories to support individuals in accessing services. So we've reserved 500 of the slots and for the lifespan for just youth. So if youth between 14 and 17 would be able to access the lifespan in their first year, because we have reserved those slots outside, so you can't have them. Also, this slide talks about if the first year. So in the first year and looking at each of those years, we had to identify how many participants and how many slots that we would need for each year and how many we would reserve. And so we did that too. And I will, for those on. Turn it over to Dr. Mills.
I'm not going to touch anything. So we had some concerns about how can providers absorb 500 youth, new enrollments and lifespan if they are already struggling to meet demand in the existing waivers. So we wanted to talk through why we think it is possible and doable. Again, mention only 680 individuals being enrolled in lifespan statewide. That's in the first year. And only 180 of those would be adults or people in urgent or crisis situations. So only 180 would be people who would need a lot of services. 500 are going to be youth, of course, as we mentioned many times, and they are likely to have use limited services. That community resource coordinator will be critical, but because they have still have school, still have EPSDT state plan, still have VR. They're not going to be using a lot of services. We also think youth and their families are going to be, based on what schools and are finding, are more engaged in using technology and are figuring out ways to provide supports. My son, who used special education and VR, we do so much support of him just by FaceTime and by technology that we can coach him wherever he is, getting on and off the bus. Are you at the right stop? Is it the right time? Are you awake? Are you going to work? Do you have everything you need? You can do so much. And he's so adept with the phone that he's probably better than we are. So there's a lot of ways to support people, and the waiver allows for virtual service delivery. And so we think that a lot of that will lead to, if we implement that well, less demand for paid staff having to do face-to-face service, which is the most expensive and most time-intensive way to support people. Some other thoughts we had is there are more options for self-direction, more services that can be self-directed in lifespan, and people will have the option to self-direct some services and choose an agency for other services. It's not all or nothing, as it is in some other waivers. So we think self-direction will allow people to find workers as well, friends, family. And then we do hope that, the rates, the fact we did a fairly recent rate study and developed the rates for lifespan, and then we're anticipating the cost of living adjustments to get from those rates and when they were set to 2027 levels. We also had over 70 providers that participated in the Readiness Initiative and expressed interest and received training, technical assistance, and funding to prepare for being part of Lifespan. So we think we'll have enough providers. We are glad to see everybody who's here. We've had really good turnout this week from providers. We know now, after all the grueling work of getting a waiver application submitted, that we basically need to re-engage with providers who want to be a part of Lifespan and start really figuring out the operational nuts and bolts of making this work. So stay tuned for more opportunities to come together. We did hear Lifespan has too many services, and so we took that to heart and went back and tried to figure out, okay, how many services do we have and why? We counted up services in section 21 and 29 as a comparison, And there's currently 28 discrete services for 21 and 29, including TCM. In Lifespan, we counted up and said we have 35 discrete services, including community resource coordination. So we do know we're offering more services in Lifespan. Some of them, many of them that are new, are short-term, time-limited services that serve a certain purpose for people. So not everybody's going to have that in their plan, and they're not going to have a million of those short-term services at one time. We also, I'll talk about staffing in a minute, but when you think about some of the new services, we really added those to make sure we're addressing youth. We're adding a new population to the waiver, 14 to 17-year-olds. And so we wanted to make sure we had services that would help them. So we got a lot of support from Disability Rights Maine and SUFU to add peer specialists or peer mentor. And you probably know that's already a core, very important service in the behavioral health side. And we believe it can also help youth, particularly, but also adults in Lifespan. We added family empowerment. CMS is now allowing states to put services in their waiver that are about supporting the family, including that waiver participant, not just services that are for the waiver participant. Family empowerment is used with other families, but types of families, I should say, but really gets at families who are isolated, who don't know all the resources that may be out there in their communities that they could access, and having someone who can help them. How do you figure out what's out there that maybe you're not taking advantage of? How do you figure out the community supports that might be out there that you could call on, and teaching them the skills so next time they feel like they need something, they have the skills themselves to figure out how to reach out. That's what that service does. Benefits and work incentive counseling, everybody supported that, because if we want more people to work, we have to address their fears that they'll lose their benefits. Coworker supports is to help with the shortage of job coaches in some areas, especially rural areas, and to help engage employers more in supporting people. Again, my son was one of the first in Wisconsin to have the chance to do this, where the agency that provided job development and job coaching worked with his employer to pay his employer to offset the cost of that employer having coworkers, natural coworkers and supervisors give him the extra support he needed to learn the job and to keep the job. So it doesn't work for everybody, but it's a really great model when it can work, especially in rural areas. If you have to pay a job coach to maybe drive 45 minutes to a work site, and then they're just intermittently supporting that person, giving them guidance, checking their work, making sure they know what they're doing next. And then they're driving 45 minutes back. You're paying for all that. You have to pay for all that time. And a coworker support arrangement can be much more cost effective, and it's invisible. My son didn't look like he had a job coach, somebody attached to him who didn't work there. It was just coworkers were giving him extra help, and we were able to offset that with a payment to the employer. So we think that'll work if you're a job coach provider, want to help develop that here. Housing startup assistance, housing counseling, I've talked about that. Community supported living, they all go together. If I want to have my own place, I probably need help to find one. And I need somebody to help me figure out the right kind of housing and what the options are, and work through some of those things like applying and, all the things that go into that. So that's what housing counseling is. Startup assistance is, I need help with my security deposit for my lease. I need help with moving expenses. I don't have any silverware for my kitchen. I need somebody to actually help me arrange my utilities. Those are things that we know once you find housing, you need as well to make that successful move. So we didn't receive any public comments that said, get rid of this service, you don't need that service, you don't need that service. Everybody was supportive of the service array. And we want to work with providers on how do you provide, how can we make it feasible for you to provide the array? We did have some people say bundle services together, merge them together. And CMS really isn't a great fan of bundling services. But the other thing is it doesn't change the fact you've got to be able to deliver all those components if you put them all together. So we want to go forward with being able to identify for people, what do people need to reach a goal? What is the thing they need right now? And be able to authorize that. We did recognize, though, that I don't want anyone to think they have to staff different kinds of staff for every different service. We did our best to make sure that certain staff could qualify to provide multiple different kinds of service. And I really hope that'll give them a little, maybe they'll enjoy their job more because there's a bit of variety in what they're doing. And we wanted to also create a career ladder. So they could gain skills over time to provide some other services that, and the services that pay at higher rates should be able to translate into higher pay for those workers. So there's a way that they can build their skills over time. But we have a lot of services I think can work well together. You all know what job coaching is. Home-based independent living skills is much the same. It's just you're at home teaching somebody how to do a task that's a home task. But job coaches, they know how to break down tasks. They know how to teach. They know how to fade. They know how to incorporate technology. And so they can apply that in teaching me how to run my washer, teaching me how to, fill my dishwasher, or whatever it is I'm trying to learn to do at home. So think about that. Employment specialists who help people find jobs. They're the community connecting and relationship service, very similar. You're not going out to employers, but you're going out to other community places and people, and you're trying to make that connection and get that connection set up. So there's a lot of similarities there. And then of course, people doing personal and home-based assistance can stay with people and move into the community and do community connections assistance. People should be able to have the same staff. If that staff works really well with them, move between different services. We want to talk about billing documentation. We're involving the program integrity unit. We want to get away from DSPs having to do documentation that's so focused on billing and then may not be very valuable for any other purpose. We want to look at how HIPAA compliant AI can help DSPs do documentation much more efficiently and much better over time. We got, AI is here to stay, and it's just about how can we use it to help us with our work. And of course, people writing notes is a really challenging thing. I've never heard a DSP say that's an easy thing to do. So how do we use AI? But what we want to do is we start to work with you more now on, let's get serious about how these services can be provided, is show you kind of the staffing and how you could hire one staff and they could, with the training we have, which isn't a huge lift after you're a DSP, could provide multiple services. So you would have that capacity. Oh, I did that too. What did I do? Oh, there we go. Oh, geez. Okay. Well, I'm sure glad we're near the end. Now what? Oh, there is one. Put that. Let me see. Ah. This is just too cool technology. I can't. Okay, now I'm afraid. So again, like I said, we want the readiness initiative. It was a while ago. We all understand that. We want to pick up the engagement again, and I'm excited to do that. Delays in services. We got comments about how are you going to authorize these services when you can't timely authorize services now? So we want to tell you what we're thinking about that. We do not want delays in lifespan, delays in service starts to be caused by the service authorization process. There might be other reasons why, people picking a provider, providers having staff, but we don't want it to be the service authorization process. The policy now is that generally, if a signed, complete person-centered service plan is submitted to ODES, the authorization should be put through and done within 14 days. We want to keep that standard in lifespan. And you're probably saying, yeah, but why? How? Yeah, but how? One of the things that we recognize is that clinical team that does all the authorizations is currently spending about 75% of their time with these authorizations for agency group home services, reviewing all that information. You have to fill out all that detail for each person that gets at their what is authorized. When we move to agency per diem, that goes away. You have a support needs level. You have we know the size of the group home you're going to live in, how many people. And so we know your per diem. And it's going to be very straightforward to authorize that. You'll get, if it's a year authorization, you'll get the 350 days, which means you get 365 days, but you get paid within 350. So if they're gone 15 days a year, you're still getting what should be the full year's per diems. So that'll be really take so much time off their plates. And we believe that will free up the time they need to do the authorizations and lifespan. And most people will be youth, and they won't be using a lot of services. Provider implementation plan, service implementation plans, we did hear, too many services, we'll have to do all these extra SIPs. And again, want to work with you on the process. But what we're thinking is if you're doing a short-term targeted service, that SIP does not have to be long because that service is very well defined. It's time limited. It has a very targeted goal. It's not going to be a big SIP. If you're getting a authorization for like 20 hours a week for 52 weeks a year, that we would expect would be a more detailed SIP. That's a lot of service. So we do feel like some of the new services are these time-limited targeted services, and the SIP should not be a big lift, and we want to make sure that is true in practice. So again, that's going to be some of our topics of what we're going to be engaging with you on.
So when we talk about next steps, what's next up for the lifespan waiver? There'll be a back and forth discussion with CMS regarding the 2 waiver applications that they have. So we'll start a call with CMS. They'll have preliminary questions that they want to ask to talk about the design of the lifespan waiver. The lifespan waiver is not new to CMS, so they've been working with us for the past 2 years on those services and supports, already letting us know what they could approve, what they could not approve, and how we should structure certain elements of the lifespan waiver to fit within the requirements of the 1915C waiver. And CMS uses it's a technical guide. It's the 1915C technical guide. That's what CMS and their consultants use when they're reviewing waivers. And so there's specific criteria that a state has to meet in order for CMS to approve that waiver. So we'll have the back and forth with CMS. That typically there's a 90-day clock. There can be times where you go off the clock or on the clock, but there's a negotiation with CMS on before it's approved. During this time, this is when we'll continue to work with all of you, families, and others on the operational day-to-day guidance that needs to happen, as well as the creation of the main care rule. For anyone who is wondering, the main care benefits manual will have a new section, that's section 24, that will be the lifespan waiver. That main care rule will go out to public comment. Again, we'll receive all of the public comments, we'll respond to those public comments, make changes to the rule as a result of that, and then we'll submit that rule to the legislature on or before January 8th of 2026, so that they can do their legislative process, which includes a public hearing as well, before the implementation of May of 2027. And so we are working on rulemaking now that we've finalized the waiver application, and we'll continue to have partnerships with all of you and others around those operational needs from now until May. More information will be continue to be shared. We have a specific lifespan Gov delivery mechanism, and so you can go on to the main.gov, and when it says sign up for information, you can go in and you can select the lifespan waiver, and that's how you can receive updates. We send updates around the lifespan waiver. You can also use this QR code, or you can type in the address goes directly to the Lifespan webpage. So we'll be posting the two PowerPoint presentations that we have, this one for providers, and then the one this afternoon for individuals, families, and advocates will be posted on our webpage, as well as a recording of the presentation for those that wish to view it in that manner as well. Also, we have a feedback form. So we have reviewed feedback. So every session that we have, we invite people and encourage people to go to this with your smartphone and the QR code to go to this link to the feedback form. There's a number of questions that we've included there, and we hope that you would give feedback. Additional questions, maybe there's something that you don't want to ask today, but you want to give us that feedback. And so please, this is another opportunity to provide that feedback for us through that feedback form. And so now we will open it up for questions and answers for people in the room. And we have a mic so that people on Zoom can hear the questions. Who wants to go first? Great, thank you. You do need a mic for the people who are on the Zoom. Yes.
Hello. So my question is, we provide personal emergency response services. Is that going to be covered under, you said assistive technology is not going to be covered under this waiver? Is that something people can still choose under one of the services that's not covered?
Assistive technology is included in the waiver, as well as remote monitoring. We did not include PERS, Personal Emergency Response Service, as a separate waiver service. And I don't know that we actually had any public comments about that. We are working with Station MD through our Rural Health Transformation grants, and working with them and piloting. We are thinking about future services around personal emergency response service, which is, for anyone who doesn't know, that is in our existing waivers and services for our age and physically disabled population. It's a way that if somebody's in an emergency or they need support, that they can use technology, or technology can alert a provider that there's a need for emergency services or another type of response. But we don't have PERS as a discrete service in the lifespan, but we do have assisted technology, and there are individuals that access those PERS device through assisted technology and then data transmission.
Yes, because it is covered under section 19 and 63, and we're contract with the state for that. So how does one go about as an ancillary service contracting for this, for our services?
Great question. So the plan, Brett, now is we understand the state, as all states, are embarking on the journey of revalidation uh, unexpectedly outside of our normal course of business. So we know that there will be some delays in that. So we've made a decision for existing Section 21 and 29 providers that they will work with them so that there's not a need to immediately do an enrollment. But for a provider who's not within Section 21 and 29, you would have to go through that approval process with ODES and then the enrollment through MEMS. But if you send us your information, we would like to work with those providers, especially the children's services providers who are not yet enrolled to provide these HCBS services to help through that process.
So you were saying send information to you or go into the ODES website and sign up?
We have a specific email address for the lifespan waiver, and I am drawing a blank as to what that is. Craig or Jen, what's the email address for the lifespan waiver? Okay, so the email address is OADS, OADS, lifespanproject@maine.gov, Gov. Yes, OADS, OADS lifespanproject, all one word, @maine.gov.
Hi. So the initial launch is going to be with youth and with people who might be in emergency situations. When is it expected that people already receiving Section 21 and 29 would be able to have the option to enroll into Lifespan? And when in that process does targeted case management hand off to a community resource coordinator?
Sure, great question. So we reserve capacity for youth to access the waiver in year one, as well as for individuals who don't have any waiver services or are in emergent need in year one. For individuals who are on Section 21 and 29, they can voluntarily transition if they want to into lifespan in year two. And then what happens, they're essentially bringing over their funded offer from 21 and 29 and moving it into the lifespan waiver. We hope that for some targeted case management agencies, including children's case management agencies, that they would continue on and deliver community resource coordination. And so that's why we've allowed for that ramp up time so that you could continue to have your targeted case manager or your children's case manager, and that person, if they become trained in supporting for community resource coordination, understanding the different elements, that they would continue. If they don't, then during that process, there would be a warm handoff. And Ali Verco, who is here as our transition manager, and her team, she oversees the community case management consultants with Michelle Corvo, who's a manager for that team, and the community resource coordinators. And we have Katie here, who is a community resource coordinator for the state. They'll be working closely with children's and targeted case managers on that process to ensure that there's a warm handoff. We've heard loud and clear from many families at times that there doesn't appear to be a warm handoff between the children's services case manager and the adult case manager. And so we're working on developing support and training to support a more seamless transition. But great question. Anything that you want to
Thank
add,
you.
Ali or Katie?
Sorry. I was just going to say, we are also willing to come out to children's services, case management agencies and talk more about the lifespan waiver. Already this week, I think we've had 3 or 4 providers reach out and ask if we could just do a smaller meeting with their teams. So just, oops, sorry, I keep forgetting. So just reach out to us or whatever, and we're happy to coordinate that.
I would just add, since community resource coordination is a waiver service, it would become active the first day of the person's enrollment and lifespan. And so targeted case management could bill up to the last day before that.
Not to complicate matters, but we've also included a transition case management service so this is primarily to support individuals who are in institutions. So we know that there are a number of youth who are in ICFs or other institutions, some in-state, some out-of-state, including people who are in nursing facilities. And so this service, it helps the person to do planning 60 days prior to the start date of the waiver. And so that person would be assigned and they would work with the person while they are in the institution. And that is new to Maine. It's not new to CMS. It's been an option for many years now, but it follows, if anyone knows about money follows the person, it follows that same sort of model. That's the service that we've are using in the lifespan. For that, there's some billing requirements that are unique to that service, and we're happy to talk further about that if somebody's interested in how to support that service.
My question kind of dovetails the other one. So you said that when you roll it out, you're going to do it slowly and do, I think you said 50 a month. When you open it to section 21 and 29 people to, voluntarily, are you going to cap how many can switch over at one time to keep 21 and 29 from collapsing? Is there a plan for that? And to make sure that there's enough people to cover them on the lifespan waiver?
So the suggestion is to somebody who wants to transition to lifespan, we would stop them.
No, if they're on 21 and 21
Yep.
now, 21, 29 now,
Yep.
we're a year out from lifespan and they can voluntarily go over.
Year
Is
two,
there a
yep.
cap of how many the state's going to let do that at one time?
No, there
Okay.
is no plan to tell in year 2, that's when individuals could start to voluntary transition to services in the lifespan. There's no, we don't have a mechanism right now in the lifespan to tell them to cap the number of people because they're bringing over their slot.
That's the second or third time we've heard this week about incrementally allowing transition. So I guess it could be potentially possible that in the same way the state is rolling out the new slots over, so many a month over 12 months, that it could do that. But I think what we are committed to is a really good transition process. It's super important, obviously, that everything's in place, that there's no gap in services, and that people have made a fully informed choice before they do this. So we are developing, I don't know, it's called options counseling in other states, a process that everyone who wants to transition would go through to make sure they're fully informed, making that decision, eyes wide open, and everything's in place before that switch of enrollment happens. So I just think, I don't know, Derek, if you had like 200 people who wanted to transition the first month, in all likelihood, you'd have to stagger that just to make sure you got it right. That would be my.
Exactly what I was asking.
Yeah.
Thank you.
Yes, great question. I don't think there wouldn't be a collapse for 21 and 29. Primarily also in 21, 75% of people in 21 are in agency group homes, and agency group homes is in the lifespan. So the providers would be providing lifespan and agency per diem, both on 21 and the lifespan, and the rates are the same. So there wouldn't be any change for that, but there would be additional services and supports that person may choose to do. We have less change in 21 and 29, but like in other services, Section 19, Section 18, and Section 20, sometimes people choose between those three waiver services, primarily with Section 19. So great suggestion around thinking sort of our capacity too around accepting. So if all 2,000 people in Section 21 decided we want to move to the lifespan waiver in year two, I don't think it wouldn't be physically possible for us to do that in a timely way. So that would be operational guidance I think we'd have to develop. But if we were to truly phase in that, we would have to include that in the waiver application to tell CMS how we would do that. Yep, great question. Thank you.
Just a quick question about the targeted case management. And from what I'm hearing today is you have the two agencies that you're going to identify to roll over to the resource coordination.
Two per region.
Yeah, two
Yep.
per region. If you start the way it's going to be put in place, if you start with youth and eventually going into Section 21 and 29, eventually the numbers are going to reverse as far as what's being provided for targeted case management now shifting over. If it's only two per region, what I'm hearing is that you're doing that now to get a better understanding of the how-to, make sure that you know what you're doing in order for it to be successful. Once you have that determination, is it going to be opened up to other agencies that may not right now be robust enough to handle the system going in? And will it be opened up for other agencies to start doing resource coordination in the future?
So first I'll clarify, it's two minimum per region, so you could have more depending on what the proposal is and whether or not the agency could say, here's how I'm going to deliver the service. And there are a number of places in that B4 application where we have to say, here's what the state will do. So if there's an experience where there's a delay in access to the lifespan because of case management, then the state's obligated to, we bring our own staff in, we hire our additional staff to meet that need. But as we're moving through each year, we've already built in and clarified in the waiver application how we would essentially go back out for a request for a proposal to elicit more to build the network. So as we anticipate 10, 15 years down the road, the number of community resource coordination agencies will ebb and flow based upon sort of the experience that we see. And so we're able to make adjustments through that process because we've outlined it to CMS how we would monitor access, how we would monitor services, and what adjustments we would make, as well as the corrective action process. So if an agency their experience that people have is that they're not satisfied with their experience, or or people are not being seen or heard, then we would also build in that process of how an agency would work with us on correcting some of those deficiencies too.
Okay, who's next? Yes.
Hi, my question is regarding the share living provider. So, Lifespan have application we can do for share living provider, or we need just going to those agencies we usually going?
So if an agency is a current Section 21 or 29 agency and is approved to deliver shared living, then you would be approved to deliver shared living through the lifespan. If you're not an agency that's approved to deliver shared living, then we are working through that process to get through the backlog of existing applications that we have for people who are seeking to deliver 21 and 29. And we would be opening up the provider application process specific for the lifespan to review agencies for approval, and then of course licensing process too for the home and community support services licensing rule. And we do know that we would have to potentially look at other changes. So there's a lot of other rules that also will need to be changed too to support the lifespan.
So if I understand that, the lifespan going to start May 27.
Correct.
So we can start submitting applications, or we have to wait?
Our first goal is to develop a process that's going to be fair to everybody, and then open it up for approval for lifespan for agencies that are not yet approved to deliver 21 and 29. So more to come on that information.
Thank you.
Hi, Derek. I'm Jennifer Putnam from Waypoint, and I don't have a question. I just have a comment. I just want to express my continued concern about provider capacity to stand up this array of services alongside the 21 and 29 services that we're already providing. And given the limitations at the state, I just have so many concerns about how this is going to be done well, and whether or not the administrative burden on all of us will overwhelm the benefits that we might see from some smaller changes within 21 and 29.
Thank you for that.
Good morning. Laura Cordes from the Maine Association for Community Service Providers, MAXB. I want to thank you, Derek, certainly Betsy, your team, for doing another round of information sessions around the lifespan waiver. You know, over the course of now 5 years, this is the third tour, as you mentioned, and I just can't say enough about the ability to have questions, answers that you can hear in a room with some context versus FAQ, that's 20 pages long. It really does make a difference. So thank you for all the work you and your team did to bring folks together. My question is really, I'm going to start with a bit more of a comment, and that is, from the provider community that's been participating, both in good faith, but just actively, thanks to the opportunities over the last 5 years to participate and give input. It was only in April that we saw all these pieces come together in the application. So, the service descriptions tied with the rate for the first time, those weren't available when folks were doing the project to springboard and look at this. So having all that information together, along with the capitations, the authorizations, the staff training, was really, really helpful. At the same time, very concerning. And I know you've seen our comments, and I appreciate the thoughtfulness in making some of the adjustments. But piggybacking on Jennifer Putnam's question, mine is really more directed as well at the capacity and service sustainability. And I'm pulling from some of the numbers that were in the application. The department's own projections showed that by year 5, 20 of the 35 lifespan services will serve fewer than 200 people statewide, 18 fewer than 100 individuals, and 13 fewer than 50. So once you divide those numbers regionally, the potential utilization for some services become really small. And at the same time, providers want to support folks, right? We want the smoother transitions for youth to adults. We want greater opportunities for independence and all the goals that put forward in the lifespan waiver. But a lot has changed in the last 5 years. And in particular, when providers are thinking about, and this is a conversation that I hear from our members, we just to serve one person under a new service, the investment that a provider needs to make and staff training, back of the house operations, billing, databases, all those pieces are truly an investment. And what has changed in this state, in the last couple years, for reasons that we could talk about, I'm sure, at length, but is that the current system is under-resourced. The state had made a decision for the last 2 years not to fully fund or even put forward the dollars for state obligated COLAs. They also made a decision to hold back on its own rate study recommendations for putting forward funding or implementing the new rates. And I'll have maybe a second question about what that looks like in the next cycle if you're going to launch without the dollars there for the current system. But the bottom line is providers are taking a risk to put something forward at a time when the dollars just, aren't there to do so. So what is the department doing or looking at right now, knowing that it's under-resourced, to say, oh gosh, what can we do to support providers to do this? Have you looked at your own numbers and then thought about, oh, is there provider capacity to deliver and stand up these smaller services? And do you have a backup plan for, if you're bringing people onto a waiver and those services aren't there, what would you do to, make sure that they happen? Because I just think services on paper, fantastic. But again, if we're creating a system where people can't access it, then, we're not doing anyone good. Thanks.
Great. Thank you for that, Laura and Jennifer. Great questions and comments. Just speaking on behalf of the operating agency, so those are our conversations when we're talking with our sister agency, Office of Main Care Services, which is the state Medicaid agency, which is responsible for ensuring that there's a rate methodology and a rate system, and we work closely with OMS to put forward future budget initiatives, and those conversations happened, and Betsy has those ongoing. Director Hopkins has those ongoing conversations with the Director Prober of Office of Main Care Services. So I can't answer some of those questions around those budget initiatives and what will be submitted for the next administration. But those are conversations that we're having, as well as internally for a ODE's perspective, how can we support providers, how we can make changes to our existing requirements, looking at our evergreen system, how can we remove some of those documentation requirements that don't always lead to great outcomes. So those are discussions that we are having of what we can do with what we have now to help support providers moving forward. So we know that there's a new budget, and the budget that we have now, it's already we have it, and so we don't know what the next budget will be, but we do put our best foot forward to ask what we and ODES works with Office of Main Care Services and of course the Commissioner's Office on putting forward a responsible budget that would help launch the lifespan waiver. As far as the capacity and the utilization, we have ongoing questions, and that's the work that we do with CMS. Because you have to base utilization, basically, what is the experience? And because some of these services are not used as much as we think that they should use in existing 21 and 29, so we have to use those historical utilization, and that's what the waiver application is. It sort of says, here's the existing services in 21 and 29, how many people are using the existing services in 2020 and 21 and 29, and that's what we put forward. on a yearly basis, we do annual reports to CMS, and that's where we outline what was that historical utilization. And then there's questions about what's happening in this service. State, will you make adjustments or will you make changes? And then we work with CMS on ultimately, do we make it changes in a service based upon the experience? So each waiver and each waiver amendment, that's the opportunity to make those changes to better reflect what's happening. Dr. Mills, if there's anything to add?
Well, I go back to my comment about if we take a bunch of these services and put them into one, provider capacity still needs to be there to be able to provide any component in the service. You can't just have a service provider that says, this service includes an array of components, but I can provide this piece or that piece. Because you're going to end up getting the referral for very targeted goals. Yes, it'll be under one service category, but you'll still have to have a way of delivering that service to meet that goal. It'll probably have, different amount, duration, and frequency. So, I don't know that putting it all together really makes it as easy as you think it might be. I think the key is how can staff provide multiple services? So even if you bundle them under one category, how can a staff person provide any of those components? So whatever the referral is for, you can do that. And I think that's what we need to work together on. Because in the end, if you put them all in one service, it doesn't change the fact you need to be able to deliver all those components.
Hi, I just have a question on regarding if individuals choose not to transition over to the lifespan waiver and just stay in section 29 and 21 services, are they able to continue to receive BHH services or do they have to discontinue those services as well?
You can't have BHH and 21 and 29 currently. So there's nobody on 21 and 29 with behavioral health homes unless there's no duplications.
Yes, so I currently supervise over adult and children BHH services for Spurwink, and we do not have targeted case management, but we do have quite a few individuals that my case managers are supporting that are receiving section 29 and 21 services. And they actually are the ones that are doing their person-centered plan and things like that.
Yes. Yep.
So my question is can they continue with BHH services with that support?
They can until until BHH ends.
Okay.
Of course, for the children at
21.
Up to 21. Yes. Sorry. Yeah.
Oh, you're fine. So I just wanted to make sure with that. And then a follow-up question with that is with BHH, these case managers helping individuals in section 29, 21 services, is there a plan if they choose not to go over to the lifespan waiver to have them have access to Evergreen? Because I know that is something that BHH providers who are helping with that, they do not have access to that service.
That is a great question that has not come up. We have long said, please access Evergreen. So I don't know if you supervise, so please go to your management because there is no prohibition for children's case manager to access Evergreen. It's been more of we don't want to access Evergreen, but we're happy to work with providers on having a profile and training on Evergreen. And we are making changes to the Evergreen system. We have those in place and we're planning for that that will support everyone who's using Evergreen in the future.
That would be amazing. Thank you.
sometimes I've heard from people who don't necessarily want to make comments in a room like this. So you're also, please provide our feedback, or you can email us at odes.lifespanwaiverproject@maine.gov and to provide additional questions and feedback. And the next step, what we talked about is we'll regroup. We're thinking about how do we target providers around residential, data employment, and to have those conversations also around the advocacy around different components that Laura, you talked about, and Jennifer, you talked about, that would be important as we're transitioning into a new administration. And we'll continue to work with CMS throughout this entire time and receive feedback. Ultimately, we need to have an approved waiver with CMS to move forward, and to have an approved rule which gives the state authority to ensure that the service and supports are being delivered in accordance with that waiver application. So if there aren't any other questions or comments, then we will turn off the recording, and then we'll continue those conversations. So if you're a children's case management agency, please make sure to touch base with Allie and Katie before you leave, because we want to connect with children's case management